So we are in live now.
Dear Facebook Urology viewers, good evening, one and all. As you all know, we are doing every alternate day surgical technique-based presentations. As you all know, that today topic is nerve-sparing radical prostatectomy. As you all know, that radical prostatectomy has changed in the surgical technique point of view, as mentioned by Dr. Ashutosh Tewari sir's famous article that open surgery is totally different because of the from the laparoscopy and now robotic technology, because your entire view anatomically is totally different. So last 2 decades, significant changes have happened in the field of robotic prostatectomy, mainly because of the robotic technology. Way back, maybe 2 decades back, Dr. Institute has started by Dr. Manimenan. When I was going through the CV of Dr. Ashutosh Tewari sir, I came to know that he was working with as the along with Dr. Manimenan sir, and then he developed this much skill and became now the renowned international surgeon at New York. Dr. Ashutosh Tewari is actually from India, and he is the alumni of SGPGI, and he went to USA and then joined with the team of Dr. Manimenan sir, and then he pioneered, and he is one of the surgeons who was the co-surgeon with Manimenan sir during the early part of robotic prostatectomy, that is first radical robotic prostatectomy. After that, he has done a lot of research at genetic level as well as the anatomy as well as the technical level, and now he has done more than 5,000 urologies. I am proudly say that he is one of the most experienced surgeon in the USA as far as the robotic prostatectomy concerned. The next step is nerve-sparing radical robotic prostatectomy. You all know that the sphincter as well as the continent, the erection, both are connected with the sympathetic and parasympathetic system as well. So this neurovascular bundle is very important anatomical structure which comes from the posterior aspect of nerves and then conglomerate on the lateral and posterior aspect and become a specific nerve at the apex of the prostate. So if you damage that because of the cautery, because of the inadvertent cutting, like in nerve-sparing radical prostatectomy, you may have lesser results related to the incontinence as well as erection. Today, our main focus is on the surgical technique related to the nerve-sparing radical prostatectomy. Ashutosh Tewari sir, if you do not mind, I like to ask you about your career a little bit, maybe around 5 minutes. Good evening, sir.
Sure, Dr. Chandramohan. Really thanks for inviting me to share my thoughts about nerve-sparing robotic radical prostatectomy. As regards the career, this is a journey, and I was lucky to have real nice mentors in my earlier days, and then when I moved to US, I continued being part of good programs. In India, I started in a place known as Kanpur, and the two professors who were very important in my career were, one was Professor Tartachan, who was a general surgeon, and other was Professor Razdan, who was another general surgeon. Then I had a chance to work with Dr. Samiran Nandi in All India Institute of Medical Sciences when I was thinking about doing a PhD in gastrosurgery. I moved on to Sanjay Gandhi in Lucknow, and I was the first MCH with Dr. Mahendra Bhandari, and I think he had a major impact on me. I went for a short while to do transplants in Royal Liverpool Hospital with Mr. Bob Sills, then moved to UCSF with Professor Parinchari Narayan, and got involved with the prostate cancer research, moved to Michigan, was part of the first 1,000 robotic radical prostatectomies being done in Michigan at Henry Ford. I was lucky to be trained by Dr. Menon at that time. I moved to Cornell, and then for last about 7-8 years, I have been at Mount Sinai in New York. And I think this journey is still going on. So let's get on to the topic of what it means to preserve the
Yeah.
nerves. And if you think it's okay, I
Yes.
will share my screen.
Yes. Over to you for your presentation. Thank you very much for the invitation.
Thank you. So I think it's important for us to appreciate that there are many operations we do. I remember my general surgical days when I will remove a big uterine tumor or a big ovarian tumor or a big tumor from the other organs in the body. And that just mere removal of that tumor was a big achievement. Then I got involved with the more delicate surgeries, and I had a chance, as I mentioned, to work with Dr. Samiran Nandi. And then it became more important that as you get onto more complicated surgeries, what you take out is very important, but what you don't take out is also very important. As we were working on the porta hepatis or working with non-cirrhotic portal hypertensions or working with deep pelvic surgeries in the general surgical days, I started appreciating that surgery is all about understanding the anatomy and also understanding the applications during surgery so that you can leave a body more functional. So that functional aspect was very important in my understanding as I was evolving as a surgeon.
Sir.
We got involved with prostate cancer surgery, and before coming, I mean, I think we had less of an interaction with an operable prostate cancers because early on, most of the cancers were being picked up when they had symptoms, when their PSAs were very high or they had a bony metastasis. So finding cancer early led us to start thinking about different approach of managing this cancer. And there was a parallel work being done by many other programs in the United States. So very soon I realized that in order to be a good prostate cancer surgeon, you have to be three different kind of individuals. One, you have to be a cancer surgeon and you have to make sure that you take everything out which needs to be taken out. Second part was that you have to be a neurosurgeon, and the mindset of a neurosurgeon in dealing with the nerves and delicate structures, that was an important part of this operational learning. And the third part was you take it out, you leave something behind, but if you don't leave something behind in its natural form, I don't think it was going to work as well. So reconstruction and restoration of anatomy became an important component. And these are the three key pillars in my mind, which lead to a good or an average outcome in prostate cancer. While we are going to talk about prostate cancer and everything about sparing the nerves, I do want you to understand that there is a very love-hate kind of a relationship between nerves and prostate cancer. This is one organ where the perineural invasion is very common. The other one, if I remember correctly, is a pancreatic cancer. So somehow, same nerves which we are focused on saving may actually be colluding with cancer and helping them escape, and sometimes even helping them become more aggressive. This is a paper, these are the two papers written by one of my own star residents, Ali, who has looked into autonomic nerves and especially the sympathetic autonomic nerves and how these autonomic nerves can actually interact with the cancer and make it more aggressive. Not just a discussion about the perineural invasion, but it can actually activate what we call an angiometabolic switch and make the cancer more aggressive. So while we are thinking about how to preserve the nerve, we should also be thinking about when not to try to preserve the nerve, because sometimes these decisions may have an impact. So a Gleason 9 and a Gleason 10, where we are expecting an extracapsular extension, in fact, we have to rethink our strategy as to how much of a nerve we even should be thinking about sparing. Having talked about that, let's come on to an understanding what is the process of how this cancer is evolving. And I'm taking you through a journey inside the prostate. So this is the bladder. You're going inside the prostate. You're seeing one of the acini where one rogue cell fills up the acini, the gland. that was the Gleason 6 cancer. Then it invades into the stroma and it's in pattern 4. Now it finally comes close to the peripheral or structures and blood vessels and the nerves. And once it finds its way outside the organ, that is where it becomes a lethal cancer. And that's the challenge with the prostate cancer, that many of these cancers are very indolent, but some of them evolve into a very aggressive clone. And once they are out, they can spread to the lymph nodes, to the bones, and that is what becomes a metastatic or a lethal prostate cancer. And at least in the United States, it still manages to kill about 34,000 men. So this is a cancer of contrast. On one extreme of the contrast is a very indolent cancer, which will never budge, never move, never will cause any problem. But on the other extreme is a lethal cancer, which can potentially kill within few years. And I have had literally thousands of both extremes of cancer. I kind of have one of a very large pool of patients who are on active surveillance. While I may have done more than 7,000 of these robotic radical prostatectomies, my learning happens from studying the pool of patients who are on active surveillance and how they behave over years. What changes inside them? What happening at the genomic level? What happening at a molecular level? What is happening in the inflammatory milieu? What's happening in their peritumoral microenvironment? What is happening in their immunological profile? What's happening in their molecular markers, and what is happening on their MRI images? All that tells me how things change and how this cancer escapes. And understanding that is very important. And this is one of the pictures in which we have an immunostain of a cancer. This is all prostate cancer at a different magnification. The extreme right lower are the highest magnification, and that brown structures in the center is a nerve fiber. And that nerve fiber is stained by a stain known as SA100. And on the surrounding areas, those blue cells are the cancer cells stained, but with what we know now is a PSMA stain. So cancer cells have a preferential affinity of finding its way out of prostate, traveling around the nerve in the perineural sheath. This is a microscopic picture. It's very obvious. But when it is happening in a real patient and in the early stages, it's very difficult to differentiate that with the naked eye. So that is where the challenge comes, that on one side, I want to save everything. The other side, I don't want to leave the nerves which have a nidus of a cancer. And that is what makes this operation very interesting. Yeah. It can happen anywhere between 10% to 40% of the patients that there may be an extracapsular extension. And if I remember correctly, having had the discussions with my colleagues in India, sometimes the incidence may be little in range of 25, 30% in India that the extracapsular extension is happening. So defining that is also part of our responsibility, so that we choose the right patient for the right operation. Then comes the challenge about the nerves. These nerves are actually very close to the prostate. Not only they are close to the prostate, as you will see in future, they are sometimes embedded within the outer layers of the capsule. This led me to start looking at this operation in a more anatomical way, more microscopic way. And this is in the year 2003, when we had done maybe a couple of hundred robotic radical prostatectomy, and I was still in Michigan. And I remember collaborating with my ENT surgeons who had some funds to have cadaveric dissection for the head and neck. They were never interested in the male pelvis, and I was very much interested in that. And I started looking at the fresh cadavers and understanding the anatomy to the level which I can now replicate into a surgical procedure. I started seeing structures on the anatomical specimens, and I started correlating them into the actual surgical field. And the robot did help. I mean, robot has evolved over many generations. And as you can see, we even have 2 single port robots. All those things actually led me to have what you call a vision and magnification. Those 2 things help me in seeing things different than what I was seeing when I was doing an open radical procedure, where you have a unidirectional view of the pelvis deep inside, sometimes obstructed by the bony structures, sometimes obstructed by a distance where you can be, even if you put on a loop or a magnifier, there is a limit to how much I could see. I definitely couldn't see all the nukes and corners. So we started looking at different studies in which we compared the laparoscopic and robotic and open procedures. And it became obvious very early on that robotic approach was giving us a vision. Robotic approach was giving us less bleeding, and robotic approach was allowing us to suture things much more better. But it also became obvious that this robotic approach has a different vantage point. You see things very different than what you were seeing when you were doing an open. And you were lacking one thing, which is your feel, your tactile feedback discussion was not there. So that led to a different set of challenges. And I streamlined my thought process about this operation into thinking about three discrete but interconnected goals. The goal number one was that why I am doing this operation to get all the cancer out. And in order to get the cancer out, the surrogate endpoint which we have is at least at the time of surgery, I should get a negative margin. Having a negative margin is an important goal. But very close to that important goal is ability to maintain the urinary control issues. And it's not easy. Body has its a perfect balance, and then we go and disrupt that perfect balance. And we need to understand the dynamics. We need to understand structures. And then the third part was that having a negative margin, having a good urinary control system, and still maintaining an erectile function in the patient. And these three discrete goals had different challenges. For the margin, extracapsular extension, which could be hidden, was an issue. Inflammation can mimic extracapsular extension. Inflammation can mask the normalcy of the tissue, and that was my enemy. And then the third thing is at the apex, everything came so close to each other that even with a good vision, sometimes it is tricky to get a negative margin and yet save the nerve. So that is my latest goal about focusing on the apex. And right now, we have a whole team of people working on that. Continence is an issue about the muscles, the supporting structures, the angulation, nerve coordination, and stability of the bladder. And nerves, not just about the nerves. Nerves need to be vascular. Nerves need to be not inflamed. Nerve needs to be viable. And that functionality of the nerve is an important part of this discussion. These are very delicate nerves. So we started developing the technique. We started comparing what was happening. And we started defining different anatomical structures which were leading to possibility of getting a better outcome. And this is a journey. I mean, every year, every 6 months, we would focus on one aspect, find in one key picture. And this is an operation in which you put in the different pieces of puzzle over time. After doing this many, I still think this is a journey which is going on. But basically, it came down to that we need to understand the anatomy better. We need to individualize this operation to a particular individual, and we need to refine our technique. We all grew up as a general surgeons, at least I grew up as a general surgeon, and mishandling of the tissue was not easily appreciated by the teachers of that generation. You heard from them that, hey, what are you doing? Why are you being so rough? That delicateness of the tissue handling is something which is passed on by a learning, by demonstration, and by showing exactly how things should be done. So I will break my thought process into three distinct areas. Let's deep dive into anatomy. We know that there is a prostate and there are nerves around. If that is what it is, it would have been very simple. But that's not the way it is, because we thought about the bundles. There is a nerve bundle on the left side, and then there is a nerve bundle on the right side. And after the surgery, it used to be one discussion. Surgery went well. Did you save the bundle? Yes, no. Did you save it on one side or both the sides? That was a too simplistic an approach, and I hopefully will be able to convince you that it is beyond the bundle we should be thinking about. Nerves were not meant to be like a bundle. And then these nerves were not lying as in large fiber or a large pipeline, they are hidden within the layers around the prostate, very discreetly hidden. And as a surgeon, we need to appreciate those layers. We need to understand those compartments so that we can leverage our understanding of anatomy in executing something what we want in that individual patient. And then came the apical discussion, and apex is a challenge in itself. So let's thinking about the beyond the bundle, and I think you may have seen it in past, but I just want to orient. The periprostatic neural tissue is a combination of three distinct kind of nerve fibers. On one side, this is the prostate, this is the bladder, this is the aorta. And at the bifurcation of aorta, you can see the hypogastric plexus, which is a sympathetic plexus. And through the sympathetic plexus, left and a right, hypogastric nerves are going down. On the sacral compartment, there is a sacral 2, sacral 3, sacral 4 is an origin for the parasympathetic neural system. And these nerves are coming and joining with the sympathetic nerves in this area. And then there are some branches of the pudendal nerve that is a somatic nerve fiber. All of that are merging and traveling to different areas. It's like a box, electrical box. If you go to the basement of your house, all the currents, all the wires are coming and packaging around the prostate. And as you can see, it is difficult to differentiate from a blood vessel and nerve, from a fascial fiber and nerve. And think about it. This is so clear because it's a fresh cadaver. If it was a real patient, you don't have those views, you don't have those angles, you cannot see everything, and there is some blood. So understanding the anatomy becomes a challenge, and that is what I'm going to deep dive into it. So once I have dissected things out, I can appreciate that there is a dominant neurovascular bundle which is traveling in the posterior lateral groove between prostate and the rectum. And this bundle tissue has three different components. One is what we call a proximal neurovascular plate. Then there is the dominant bundle. And then there are accessory fibers which are traveling in the layers in the anterolateral aspect and behind the prostate. So the proximal neurovascular plate exists. You can see this plate in MRI, and you can see that at the lateral aspect of seminal vesicles. And sometimes it can even be damaged if we are not cognizant to this fact when we are doing a bladder neck dissection and we are too lateral. This is on the right side, an anatomical drawing showing that how this proximal neurovascular plate is associated, and just deeper to that are the seminal vesicles. There is another picture, an anatomy picture, in which I could demonstrate that these nerves are traveling very lateral, very close to the seminal vesicles. If you're not careful and if you're not cognizant, the size of the seminal vesicle tip and its location can sometimes pull these nerves onto the specimen. So you have to be in a very delicate plane just around the seminal vesicles and not put in too big a clips around so that you're damaging the nerves even without realizing that you are damaging the nerves. So this is what we call the proximal neurovascular plate. Then comes the predominant neurovascular bundle, and it exists, but in reality, it exists in about 50% of the cases. The most important erectile nerves are in this bundle, but in another 50% of the cases, these nerves may actually be traveling little away from this dominant neurovascular bundle. In the right side video, you can appreciate that I know exactly where this bundle is hiding, but I don't have to expose it in every case, but it exists in this group. And as it comes closer to the apex, it kind of converges more medially and sometimes a little bit more anteriorly. But then there are the accessory nerves. These accessory nerves are lying or traveling through the facial layers in the posterior lateral aspect and also in the layers of the denominated fascia. As you can see, this is again a brown stain for the nerves. And this is a proximal cut section around the prostate near the bladder neck and the seminal vesicle. And these brown nerves are showing you there is not one nerve. There are many nerve fibers traveling in that tissue. And as you can see, these nerves are embedded within the layers around the prostate. So the concept of a bundle to a mesh is what I'm trying to bring. And that led me to start thinking about that maybe these nerves are like an hammock, and that entire hammock is composed of nerves from parasympathetic system, from sympathetic system, and some of the somatic nerve branches are also taking a co-journey with them.
Sir, one small doubt, if you don't mind.
Sure.
You also please clarify how these are related to the inferior vesicle as well as the prostate blood supply. Because when we see the clipping of the after the bladder neck is divided, when you clip it and then go to the lateral and posterior aspect of the prostate surface, is there any possibility that while clipping the vascular pedicle of the prostate, these can be injured or not? Because they are quite anterior.
If there is an overshooting of the clip in which it is going beyond the blood vessels, yes, it can do it. But most of the time, the clips are more anterior, and the nerves at the base, which are more responsible for the sexual function, are more posterior. But if you are disoriented, or if the clips are too big and if clip is not working, it's better to just cut it, control the bleeder with whatever way you can. But understanding the relationship, and that's where I will come to the what we call the triangle of entry into the nerve preservation, and I'll come on to that.
Yes.
But this picture again shows an MRI picture, which is known as a DTI imaging of the brain, and we applied, and other people have applied it for imaging the prostate. And as you can see, there are multiple fibrous tracts are traveling around the prostate. Not every one of them is a nerve, but nerves are also embedded in there. And as you can see, it's a complex mesh of network. So we coined the term that maybe the nerve should be visualized as an hammock. And on that hammock is the prostate and bladder is lying, and this hammock is intermingling with the blood vessels. As you are saying, the blood vessels, the pedicle is right here, and it becomes simpler when things are released. But as a surgeon, we need to think about that. This is what the hammock is. And some of the branches, the important branches, are posterior, so they are less likely to be damaged by the clips, but the anterior branches may well be. But these branches may well be going to the bladder neck, or they may going to the prostate also. So what is this autonomic system doing there? They are not just there to go to the penis. They are there to kind of modulate all the functionality of that complex part of the pelvis, which includes the seminal vesicles, the bladder neck, the prostate itself, and maybe the rectal side also. All that is being innervated by these nerves. What we are interested in preserving the innervation to the sexual functional aspect, preserving the functionality of the sphincteric innervation if there is one, and the third was is a little controversial. I don't know of sure, but possibly an orgasmic function also. Because orgasm is a phenomena starting from brain and kind of having a pelvic component. And some of these nerves may be involved with all that. So that's where I came up with the concept of a hammock. But as you can see, one of my team members had put together this video. It looks very good. So we established one fact that nerves are more complex and they are not just like a bundle, rather they are like a hammock. The second part is these nerves. I can show you, and as you can see in this video, I know exactly where these nerves are hiding. And sometimes what I say, an early release, I have to do it if I'm expecting an extracapsular extension on that side. You can see the nerves, and I can very delicately dissect it out of the harm's way, even before embarking upon the what you call removal of the nerves and controlling the pedicle, because I'm expecting that I will not be coming too close to the capsule. But these are embedded within the layers of periprostatic, and I think understanding of the periprostatic fascia, what we call lateral prostatic fascia, is an important part of the discussion. And the credit for this work goes to one of my prior fellow, and who now is practicing in India, Dr. Rajiv Yadav, who is in Delhi. Rajiv was a topper in All India Institute of Medical Sciences. He spent a couple of years with me when I was at Cornell.
Yes, he was contemporary, sir, in All India Institute.
Yeah. So he is so thoughtful, and he and I used to talk about every case. And after the surgery, he will go and spend time with the pathology and look at. And my cases where I didn't preserve the nerve because they had at least 9 or more aggressive cancer, we will start looking at that. So I want you to look at this picture and imagine on the right side of this picture is the cap prostate, and the whole periprostatic tissue is from here to here. I don't know whether you can see my arrow or not. This is the outermost part, and this is the innermost part. And even in the prostatic capsule, you can see some of the cancer cells embedded within. So I said, okay, let's stain them and color them to see what is what. So you can see the capsule here. And actually, I'll make it easier. This line is just outside the capsule. And outside the capsule, you can see a couple of veins, couple of arteries, and 1 or 2 green structures. They are in the nerves. But beyond the vein, you can see there is a distinct layer, and most of the nerves are lateral to that. And then there are different planes within the planes. And then finally, there's a levator fascia, which is on the outer aspect of this discussion. So we started appreciating a consistency of anatomical structures in the periprostatic tissue. And that led me to start thinking that can I think about certain planes in that 1 or 2 millimeter zone. So I sat down, I studied as much of an anatomy as I could. I looked at all the histopathology slides. And this is very early on. I sat down and drew this, and I kind of came with the concept that maybe there are layers outside the prostate and the nerves follow a consistent traveling path in that. This is the rectum, and this is the left seminal vesicle. This is the right seminal vesicle. The vast difference is here. And this is the levator and eye muscle, which you are seeing. And the nerves are traveling in these planes, and they are traveling distally, and sometimes they are supplying to the prostate. Some of the penetrating branches are going through that. And basically, we came up with an anatomical model that, and I can see that on an MRI if I want to. This is the prostatic capsule. And we wrote a paper about the anatomical grades of nerve sparing. That sometimes if you are suspecting that the patient may have a little bit of an extracapsular extension and you still want to give it a shot in doing a nerve sparing, you can spare some of the nerves if you understand the concept of, and there are compartments within the prostatic tissue. And one of my fellows, I think Abhishek Srivastava was there, and he sat down with some of the computer modelers and created a model as to how to visualize these layers, and prosthetic veins and the arteries became an important concept. And we can appreciate that. We started looking at the grade 1 nerve sparing, in which I can come very close to the prostate. And these are the patients who have a very, very, very indolent prostate cancer. And I'm really not worried about extracapsular extension. These are the patients in which I do a surgery, and you will see the histopathology tissue like this. There is hardly anything left on the capsule. That's bare exposed. Then comes the grade 2, in which I'm worried about it a little bit, and I have left some of the vessels, the arteries and veins on this specimen. Some of the deeper nerves, I don't know the nature of that. That may be the question for my next generation of the fellows, is to understand, is it more parasympathetic or more sympathetic, the deeper nerves. If they are sympathetic nerves, they are more involved with the prostatic secretions rather than the erectile function, but we don't know right now. We are going to do some staining from that. This is a grade 3 and this is a grade 4, in which I have been a very wide. So as I said, that I can show you the different layers within the layers discussion, but can you actually see it in real surgery? So I think you can see it in a real surgery. I will give one example here, and then I'm going to show you another example in which I'm planning to do a grade 2 nerve sparing on the right side. I can see 2 planes right now.
Yes.
1 plane, 2 plane, and the third plane is coming out now. So I can find this plane because I know it exists. Eyes only sees what mind already knows about it. So you can see that there is an artery. And so I'm in a grade 2 plane. And if I get deeper than that, then I will come into the grade 1 plane. So these planes, they do exist, and it is possible to exploit them into the surgical dissection if they are intact, if there is no inflammation, if there is no encroachment by extracapsular extension. So these are the layers within the layers. So that is, I'm demonstrating the grades of nerve sparing concept, that it is possible to understand the grades concept here. And here you can see I'm leaving the vein onto the specimen because this is the place where there is a little bit of a more extracapsular extension risk. Let's continue on this journey. I hope I convinced you that nerves are like in hammock.
Yeah.
And these nerves are hidden outside the prostate in a more complex compartment-like structure. Simplistic way, there is a way to say some lateral nerves in a case where there is a minimal extracapsular extension. And if you are not worried about it, you can hug the prostatic capsule and you'll be fine. But understanding that concept led me to think about the incremental nerve sparing. Then comes the apex, and apex theory is not over. Apex is still going on. Right now, I am actively looking at apex, and two of my collaborators, Dr. Atsushi Takinaka and Thomas Bessard from France. We are working on it. My whole team, Jordan Nassari from France, who is my fellow right now, Adriana and Vinayak, who is a faculty here. We are all working on this apical anatomy right now. But I will demonstrate that how close these nerves are to the apex, and it literally takes almost like a millimeter. And there are the branching and the crossovers between somatic fibers, the continence fibers, and the erectile nerves. That all is happening at the prostatic apex, and we yet have not been totally sure about what is what. So hopefully we will have a little bit more updates next year. But one thing is sure, different other authors have looked at it. And this is Thomas Bessard's group who has looked at that nerves have, even the erectile nerves, which are going beyond the prostate, have got two targets. One target is going to the corpus spongiosum and another target is going to the corpus cavernosum. It's the corpus cavernosal nerves which are more involved with erection, and corpus spongiosum nerves are more with the urethral or the little bit of a glans discussion. If that is so, is there a difference in the course? And what they realized, as you come close to the apex, more of the cavernosal nerves were tending to bend anteriorly. And that is another appreciation we have to have, that not only you have to save the nerves, you have to do it in a way that you can save most of the nerves at the apex. So we wrote a couple more papers as to how to understand different parts of this apical anatomy and all those things. So after having a deep dive into the anatomy, I needed to kind of think about, there is no one operation for every patient, and you have to change the operation. You have to individualize. That is an important discussion. So we talked about the grades. So I will spend some time looking at an MRI. I will do a digital rectal exam. I will look at the biopsy. My team, Adriana or Vinayak or my team members, will on a daily basis spend time looking at a special kind of an ultrasound to seeing and defining the anatomy for that individual as well as it is possible. And these are my drawings. I like thinking visually so that the time when I'm doing this surgery, right base is where my mind will be thinking in a different operation. Left apex, I'll be thinking a different operation. Anterior apex, I will be thinking about a different steps. I can do anything, or we can do anything, but what is right has to be based on some deliberate decision-making discussion. And that's what I'm coming on to it. So for a short while, I will do an MRI, and I will take those MRI images and decode them and send it to Turin to Dr. Proplegia, who is a friend of mine and a very renowned urologist and a chair in University of Turin. And he will create a 3D model, and I will draw my own hand models here. and we try to combine them. And by the time the surgery is happening, we will have that model and we will try to see if that makes a difference. We were also investing, and that is not directly connected to the discussion, but we were doing in 7 Tesla MRIs of the specimen. And as you can see, MRI is not ready for the prime time, but there are possibilities in next couple of years. There may have a very high resolution MRI images, which can help us in fine tuning the surgery more than what we are doing now. As you can see, this is a specimen which has been removed, and we have taken pictures of that specimen, and you can almost see a very high resolution microscopy level detail in there. This is work in progress. But what is available right now? Based on a conventional MRI, based on the biopsy information, based on the DRE information, we had a fellow from Professor Francesco Montorsi's group in Milan. His name is Alberto Martini. And Alberto and I worked on looking in all that and then created a nomogram, which tells me what kind of a likelihood is of an extracapsular extension, not as a whole, but what is the likelihood on the left side? What is the likelihood on the right side? Not only that, it tells me a likelihood of a left and a right. It also gives me an indirect inkling that, you know what, you can try grade 2 on the left side, but on the right side, it is very likely that it will be higher than the grade 2. So you be on in grade 3. This combination of the models and everything have helped me in keeping my margin rate consistently around 10%. That is a very low margin rate, even though I operate on very high risk patients. Recent 8 and 9s are there in almost every week. 2 or 3 patients have that kind of a thing. So individualizing the surgery and using a computer algorithm and using an imaging and individualizing it has helped me in doing the right thing. And this paper is published, and I think you guys can benefit from it. It helps you in making a left or a right side decision about the nerve sparing a little bit more better. Then comes the technique, and some of you may have seen this picture. As I said, prostate happens to be sitting on a hammock of nerves, and I want to take the prostate out and leave the hammock intact. I don't want to leave it like this. Even if it is left, it is not going to be functional. And everything we can do to make it cleaner is what we are trying to do. And I think most of my friends in India have seen this plant. Have you heard and seen this plant? Dr. Verdi, have you seen this plant? At least in some part of the India, this is known as touch me not, also known as chui mui. That you touch it, it becomes limb. That's exactly how the nerves are. Nerves are very temperamental. You touch them, they go limb. But the only difference is this plant will become viable in 5 minutes. Nerves take about a year. And that is the mindset is in my mind. So that is why I will demonstrate some of the videos here to kind of show as to what I mean by being delicate. Every day I do 3 surgeries, but I'm very slow. It just takes little time to be delicate. And there are certain parts of the operation, dropping the bladder and all those things, you can catch up speed. But understanding the anatomy, understanding the layer which is there, every scissor move is deliberate in terms of what structure I'm cutting, where do I need to put in a clip, what I need to do. And we also came up with a concept that there is a distinct compartment for the seminal vesicle. And if we get onto that distinct compartment, so I'm getting into the medial avascular plane on the left seminal vesicle, and I will be able to get onto it, find the blood vessels. I'm not pulling that nerve on the side, and very delicately, I can dissect it out. Then comes your question about the pedicle and how pedicle interacts. I want you to see this structure here, and especially focus on the right side. The neural hammock, the nerves are kind of very posterior. The erectile nerves are very posterior. They have yet not gone anterior at this junction. And I will show you, that's the reason I start my operation in the midline. And midline, there is a hardly least number of nerves, and especially it is easy to identify where the prostatic capsule is. After dissecting the vas and seminal vesicles, I will get onto this plane. Everything will be relatively under vision. Scissors are my most preferred tool. I can develop a plane wherever I want it to be. This patient has a little bit of a suspicion on the right side, so I'm just taking my time. It's okay to get a bleeder sometimes rather than making a blunt dissection and creating a flap, but that's where you get the margins. It looks like there's a perforating vessel. That's okay. We'll deal with it. And once you get into the right plane, everything peels out easily. This is another example of that I don't want to do grade 1 nerve sparing because I'm worried about an extracapsular extension in that certain area. So I'm trying to feel it with the scissors. That tissue, if it opens up, fine. Let's come on to the apex discussion. And we wrote a whole new approach of looking at muscles, you membranous urethra. So these are the pictures drawn by an artist, and we are working on an atlas looking at this thing. So can you see it? And sometimes I don't do it in every case, but I can literally demonstrate the released urethra and the end of the prostate and possibly gain few extra millimeters of the membranous urethra. I'm a big believer of a sharp instrument dissection. I'd never recommend this to be done, but if the scissors is not working, I'm not shy of dissecting it out sharply as long as I know what I'm doing. I am a big believer of using whatever normal tissue which is there. If there is a fat there, I will use it to cover it, whatever I have removed. And it acts like an Surgicel for me sometimes, and it kind of creates a pad. It reduces the bleeding. It reduces. So if there is a fat around, just use it between the bladder and the nerves. So over years, we have made multiple small adjustments. And in last few years, we have been focusing on the hood technique. And if you want, I can talk about it now or some other time. If how long time we have or how much time I have used.
You can go ahead. We have up to 40 minutes finished, and we have another 20-25 minutes more.
If you guys want, we can ask questions. I mean, I think that should be
Yes,
fine too.
I like to ask questions from the chat box also. If you give
Let's
5
go
minutes.
to the questions. Let's go to the questions. This is another 40 minutes of discussion of
Okay, sir. Then we
all
will do
about
another time, no problem. We will do another
yeah,
time.
this is a lot of slides, and I don't want to rush it. There's
Correct,
a lot
yes,
of
sir. We will do after 3-4 months like that. I
yeah,
like to ask questions. Sir,
yeah.
my first question is, after doing such an extensive research on the neurovascular bundle, do you think that some says that Regis pairing prostatectomy, some say that posterior approach, some say that anterior approach. Do you think that this approach also has to be individualized depending on the MRI, or you follow same approach to all the radical prostatectomy patient? I mean to say first posterior or anterior. I don't know whether you go first posterior or anterior.
Absolutely no. I mean, I think surgery is all about how many arrows you have in your quiver, and you should be able to use the right one for the right time. If you are fighting in a very narrow space, you don't want to pull out a javelin, and you just need a smaller instruments. So I think you have to be comfortable with understanding all the approaches. There are certain cases, very good example. I mean, I think I'll show you this case. Okay.
Yes.
This is a good example. We'll set up that if I was doing this operation with an ridge sparing approach, I will not do a good job in managing this median lobe.
Yes, sir.
I have another case, which is 426 gram prostate. I will not do a good job in doing a operation cleanly. But with the hood approach or this approach, I can easily manage it. If a patient has an anterior apical tumor, I don't think I should be using that approach. So you have to have a different approaches. Don't fight for an approach, fight for the patient. Patient will declare what is the best thing for it. And if you are getting a good results in terms of continence, you are getting a good results in sexual function. If you think you are not interfering with the ureteric orifices, whatever you feel comfortable, I don't think it matters.
Sir, my second question, when you are taking multiple biopsies, like as extended biopsies, don't you think that when you are looking at the neurovascular bundle, are they not getting damaged also?
So I don't take extensive biopsies. I'm taking what you call a systematic biopsy and targeted biopsy. But your point about needle traveling through the neurovascular bundle, it's a possibility. And there may be a little different potential possibly between the perineal biopsy versus transrectal biopsy. I don't have that data in my mind right now, but this is something worth looking at it. Hopefully those needles leave the nerves still functional. And that's the reason we wait about 6 to 8 weeks before embarking upon surgery.
Because most of the biopsies are taken from the posterolateral, from the transrectal biopsy. And you will be focusing predominantly on the peripheral zone. And again, you are going from the rectum to the prostate, but obviously you are in the direction of the neurovascular.
It depends a lot on the end fire versus side fire fibers. And it also depends on transrectal versus transperineal. Both may, but this is a theoretical discussion. I don't have that data in my mind.
Third thing,
but I have seen one thing, but I have one data to report. When I look, about 10 years ago, I looked at patients who had multiple biopsies. Patients who had multiple biopsies had a delay in recovery of sexual function. At the end of 1 year, everything was okay. At the end of 18 months, things were okay. But early on, patients who had less biopsies were a little bit better. So could it be because of nerve injury? Could it be because of inflammation? I don't know, but that is a good topic for us to study.
Sir, normally, nowadays, the vascularity in partial nephrectomy is assessed by these stains like ICG. And do you believe that in future, these nerves can be stained by something which can be observed on table, so that you can think beyond what you see on robotic, the endo camera, or maybe in laparoscopy, or whatever it may be?
So people have tried to,
Intravascular injection which strains the nerves.
yeah, I mean, I think, so there are two different kinds of studies we talk about it. One is known as nerve viability studies, nerve functional studies, and nerve anatomical studies. So people have tried looking at different kind of stains intraoperatively, including methylene blue and all those things. I think vasculature has been easily shown. Sometimes people have used optical coherence tomography, or we have been using a multiphoton microscopy, but these things are yet not ready for prime time. I did a study with Medtronic long time ago with Dr. Badani as myself together. We looked at neural monitoring intraoperatively to see if the nerves are functional. And that was showing some promising results, but was not ready for the prime time. Before that, there was a device known as CAVR-MAP, which was studied by Dr. Peter Scardino. And it kind of tells you at the end of it that whether you have saved the nerves or not. I think this field is going to come up again, as not just necessarily, you're not interested in seeing the nerve. You are interested in seeing if the nerves are functional. So meaning, so if we can provoke erection, fine. Even if you see them and they're not doing anything, that means it didn't do the job. So I think that all is to be, and I think this field will evolve. The more microstimulators and nerve mapping techniques will come up.
Sir, if the tumor is totally intraprostatic, 3+3 grade, then is there any need to go for the pedicle directly in your approach? Let us concentrate entirely around the capsule without going anywhere on the lateral pedicle and attack the vessels which are entering right at the prostate, how small or big they may be, and remove something like nuclear resection in a hilar tumor, where when you are so much clear about the three layers, if it is so prostatic tumor where you are not suspecting on either sides any prostatic extension, can we go in those layers and remove entire gland like that?
So I have about 1,000 patients of that kind who have never needed any treatment. So they could be very good candidate for what we call active surveillance. But I mean, that's the challenge. But active surveillance patients of the kind which you
have 700 patients you are watching active surveillance. In the first word, you told that you are also following them and interfering what's happening with your results and
that's right. I mean, I think that so we need to be prostate cancer expert, not just prostate cancer surgeons.
Yeah.
So, and then this is one cancer which gives us an opportunity to have our thinking side and our skill side both balanced. But supposing, I'll give you an example, that there is a patient with 250 gram prostate, also happens to have an Gleason 6 prostate cancer.
Yes.
So that is a scenario you should be thinking about it. So that patient, yes, I will have to operate because there's no other treatment which will work. And I don't want to do a simple prostatectomy where there is a known Gleason 6 there.
Yes.
So there are two different approaches, and I will mention one of the approach which is being studied by Professor Menon, actually. And if you don't know, Dr. Menon is with me in New York now. And I am lucky to be working with him right now. He is moved to New York. So he is working on what we call a precision prostatectomy, in which he develops a plane, and maybe you should invite him to give that talk some other time, because he comes anterior on one side, he comes anterior to the insertion of the ejaculatory ducts, and then he develops a plane. But what you were mentioning, there is another person, and happens to be, you all know him, and you definitely should know him if you had an AIMS connection, Dr. Himmel. So yes, Ashok Himmel.
I was with him.
Yeah, so Dr. Himmel has talked about what we call a not well done simple prostatectomy, meaning you are not in the simple prostatectomy plane, but you are in a transcapsular plane.
Yes, sir. Yes, exactly what I wanted to ask.
Yeah. So I think, and I have been thinking about calling it grade 0. So I have come up to the grade 1, which is in
Yes, sir.
extra
Exactly.
capsular, but I can afford to be into the capsule, and then I just pray that I don't get an positive
In
margin.
fact, when you are
Because
scraping in fact, when you are scraping with scissors of the last layer, all the vessels are so clearly seen. My God, magnification. And that plane, can we continue up to the apex?
I think it is possible. And I also have been looking at another aspect of it. What is the meaning of a positive margin in an Gleason 7 low-grade cancer? If it is not that, and that is the answer which my team will have to give, if it is not that bad, then I can afford to take that chance and then develop this grade 0 plane, which is inspired by Dr. Himmel and Dr. Menon both. But these patients are best off just doing what you call an active surveillance. But if you end up doing it, this could be a potential, but it is very, people can get disoriented and be in an BPH plane, BPH transition zone to peripheral zone plane, rather than in the capsule plane. That's where the experience will come in. So
Yeah. Sir,
that's a theoretical discussion,
yes,
and they're not ready for the prime time.
yeah. Sir, when so much meticulous dissection, I'm remembering like microcele, varicocele ligation to this level. Do you think now the duration of this surgery, when you have planned so much MRI for every tumor and discussing so much, the duration of the surgery is prolonging over a period of time? The people say that Ashutosh Tewari finishes in 40 minutes, 50 minutes, and then catheter next day. Are you now more meticulous in preserving the nerves and taking more time and going to the apex nowadays, or like does it affect the duration of the surgery? I mean to say, nerve sparing radical prostatectomy.
Not exactly. I think meticulousness gives me, I don't have to come back to the same stuff. I mean, it's about the efficiency. So when you are deliberate, you look slow, but you finish early.
Yes, sir.
I mean,
Yes, I understand. Laparoscopy, that is commonly mentioned.
Moving around too much. I mean, I think every step, and there are steps where you pause, and there are steps which don't need a pausing. So, and at least the clock should not be in your mind. Clock, the goal is in front of you, and you will be surprised if you spend enough time in these delicate things. You don't have to come back and control those bleeders again and all those things. So I think at the end of it,
I understand, sir. Slow and steady will move the faster the surgery, and then you'll finish it in a cleaner method.
You don't have to be here, and you don't have to be turtle. Something in between is possible, and be very clean.
Yeah, right, sir. Last couple of questions. The lot much is said about the apex, because when you saved so much the hammock and it comes to a narrow point where it is concentrated to a single nerve or maybe couple of nerves at the apex, what is your take on the dorsal venous complex? And second thing is, when you are dissecting from the anterior, do you go close to the urethra? Because this capsule of the prostate, what you are talking, may not be there, and you wanted to preserve. What is your level of dissection anteriorly when you are going laterally at the apex? That video we could not see.
I think maybe this will show you.
Yeah, yes, sir. Do you cut the dorsal vein directly now?
I cut it and then suture it.
No, okay, sir. That's okay.
You can see that.
Yeah, I'm able to see that. This is mainly to have the intrapelvic part of the urethra more without damaging anything. Is it correct?
Yeah, and then I don't like bleeders. So a little bit of an open sinuses, if I close it, and then you can see that you can have as much of a length you can. This is from the back side you're seeing, by the way.
Yes, sir. I'm seeing back side. But I am looking from the front side urethra when you are dissecting. How inadvertently, to avoid the cutting of the neurovascular bundle, what is the precaution you will take?
Stay close to the prostate, have vision, and you should have released the nerves before you get onto that.
Yeah.
Before you are cutting it, the nerve should be out of harm's way most of the time.
So you follow from the lateral to the apex and then separate them and then look the matter.
Yeah, and the apex usually is the last part of my operation.
last part of your operation. Okay, sir.
Because by that time I have released everything which needed to be released.
Okay. Sir, I'm very thankful for all this highly, in-depth discussion. I really appreciate this effort you are taking last 10 years. I'm very happy that Manimenan sir is again back to New York. I heard that through Anish Srivastava sir, every time that you have worked a lot in the first 5 years when you are as a junior consultant, and then you have gone into the depth. First time I am listening to this level. If any last, it's not a question, it's a query, that if anybody wants to come to US and get it operated, what are the formalities we have? Don't mind, sir. Some people
Nowadays, it's only formality with COVID clearance.
And roughly in Indian rupees, how much it will cost if everything goes. If he's not a citizen of US, if they want to come and get it operated.
I am not the most qualified person on that. Usually we have an international department. There is a lady by name of Mona who
we can communicate with her.
Yeah,
but it is possible, sir. We can take an appointment and come and get it done and go back.
But there is no cost involved for any one of you coming here and spending a week. Just come, time, and give me feedback, and we can learn some things.
Okay. Yeah. I mean, I'm asking for the patient. If any patient wants to come.
I think those patients who want to come, they usually don't worry about the cost.
Yeah, I understand, sir. I mean, they can come directly, admit, and then get operated and go back by flight without knowing anybody.
They spend about 10 days in New York. Yeah,
10 days in New York. Okay. Thank you very much, sir. I really appreciate this very deeply thought talk. Really, we learned a lot. I hope this video will go to the juniors' minds, and they will also understand better before doing this surgery, which is complicated as of now. Thank you very much, sir.
Still, in spite of all that, there are patients who become incontinent, and there are patients who don't get sexual function back. It's a journey.
It also depends on his pre-operative sexual function. Also, there are a lot of factors. That's a big subject. At least if you are meticulous in your hands, whatever you can do it, you have explained so well. And that's what a surgeon has to do over a period of time. And I'm also happy that Nandi sir is also, when I was there, he was GI surgery head of the department, a very well-known surgeon, a great surgeon and great human being. And you are associated with him. When I was in MS,
Nandi was there, Shinoy was there, and I mean, that whole gang was there, and I was there as a officer.
Atarji made me junior consultant to Nandi sir, actually.
There you go. Yes. So convey my greetings to everyone, and thanks a lot. Okay.
Nice to know, sir. Thank you very much, sir. Bye-bye.